Okay, let's dive into this explainer and map out the progressive, totally hidden journey of heart failure. Imagine a silent threat totally remodeling your cardiovascular system for years, long before you even feel out of breath. This ticking biological clock actually unfolds across 4 distinct stages. Let's break down how this happens. In stage A, you feel completely fine, right? But things like hypertension or obesity are quietly setting the stage. Moving into stage B, the biological reality changes. Structural damage begins, even though you still feel perfectly normal. But tests tell a different story. They reveal hidden hypertrophy, a reduced ejection fraction, and elevated BNP biomarkers. This stage is a crucial window. The SDOHF trial proved that catching it early significantly slows progression. But eventually, that silence completely shatters as we cross the threshold into symptomatic stage C. That structural damage finally surfaces physically. We're talking severe shortness of breath and just totally profound debilitating exhaustion. And behind the scenes, your diaphragm, basically your respiratory system's auxiliary heart, starts failing rapidly. It suffers brutal muscle atrophy, driven by a relentless breakdown of cellular proteins and intense oxidative stress. Plus, a messed up metabolic reflex triggers widespread vasoconstriction. It's a biological betrayal, literally starving active muscles of blood. Even with the best medical management, about 4.5% of stage C patients progress annually. Which brings us to the climax, stage D. This is where the biological pump has definitively failed. With ejection fractions plummeting below 25%, severe oxygen starvation literally starts shutting down the kidneys and liver. To save the patient's life, an incredible mechanical continuous flow pump, an LVAD, is surgically implanted. A cannula constantly pulls blood right out of the failing left ventricle, routing it directly into the aorta. Since a driveline exits the abdomen, patients have to manage external batteries and stay hypervigilant for alarms. But amazingly, it works fast. Kidney function improves, swelling drops, and the patient's energy slowly starts returning. It's not a perfect cure, though. Living with this means navigating scary risks like infections and gastrointestinal bleeding. For eligible patients, it's a vital bridge to transplant. For others, it serves as permanent destination therapy. Ultimately, a donor heart is the definitive cure. So what could you do with a genuine second chance? For patients with chronic heart failure with reduced ejection fraction, the options become severely limited if they maintain a narrow QRS complex. Without baseline ventricular dysynchrony, they are completely ineligible for cardiac resynchronization therapy, leaving a globally hypokinetic ventricle with few mechanical interventions. This chart maps data from a novel device trial achieving significant reductions in left ventricular end systolic volume and sustained increases in exercise capacity. Patients walked further, reported major quality of life gains, and showed measurable increases in left ventricular ejection fraction. The clinical anomaly here is how these improvements were generated. These hemodynamic outcomes were achieved without pacing the myocardium at all. As shown in this post-implant radiograph, the pacing leads completely bypass the heart and are instead anchored to the inferior surface of the diaphragm. This is the VisONE device. It is designed to deliver asymptomatic synchronized diaphragmatic stimulation, or ASDS. ASDS leverages the normal native motion of the diaphragm, but precisely synchronizes that contraction to the patient's intrinsic QRS complex. By targeting the diaphragm rather than the myocardium itself, ASDS effectively co-opts the respiratory system, forcing it to function as an auxiliary cardiovascular pump. To understand why pacing the diaphragm affects the heart, we have to look at physiological first principles. The healthy diaphragm is a primary respiratory pump that actively modulates both intrathoracic and intra-abdominal pressures. During normal contraction, the diaphragm moves caudally. As it descends, intrathoracic pressure drops to negative values, while intra-abdominal pressure rises. This creates a transdiaphragmatic pressure gradient. The differential mechanically dilates the inferior vena cava and accelerates systemic venous return directly into the right atrium. Concurrently, that drop in pleural pressure reduces pericardial restraint. The pericardial sac subtly expands, allowing for enhanced biventricular diastolic filling. In the HF-ref disease state, this healthy baseline deteriorates. Patients routinely develop diaphragmatic muscle fiber atrophy, leading to severe thinning and fraying of the tissue under constant oxidative stress. This structural degradation alters the muscle metabore reflex. Instead of healthy adaptation during exertion, the damaged fibers trigger pathological sympathetic overactivation and strict peripheral vasoconstriction. This cascade of physiological failures creates a loss of preload reserve. The body loses its ability to recruit central blood volume to increase cardiac output without dangerously spiking ventricular filling pressures. ASDS provides targeted mechanical assistance to bypass this reflex failure. By forcefully converting unstressed blood volume into stressed volume in series with the failing native heart, it restores the missing preload reserve. This image displays the physical architecture of the VisONE system, designed to execute that mechanical assistance. It consists of an implantable pulse generator, bipolar active fixation leads, and a specialized delivery tool. The bipolar active fixation leads are engineered for immediate, sutureless attachment to the muscle tissue. Implantation relies on a minimally invasive transabdominal laparoscopy, utilizing small trocar insertion points on the abdomen. This transabdominal approach allows the surgeon to directly visualize the inferior surface of the diaphragm, entirely avoiding the severe risks of entering the thoracic cavity. Because the anatomy is highly accessible from below, the learning curve for laparoscopic surgeons is rapid. In the pilot trial, the average procedure time was just 73 minutes. Once implanted, the operational sequence is straightforward. The IPG continuously senses the patient's intrinsic QRS complex through the attached leads. Using an external programmer, clinicians set an adjustable synchronization delay immediately following that QRS detection. Exactly at the optimal phase of the cardiac cycle, the device fires a low-voltage pulse, triggering a precise diaphragmatic contraction. Careful voltage calibration keeps the stimulation threshold strictly controlled, ensuring that this synchronized contraction remains completely imperceptible to the patient. The result of this hardware engineering and surgical pathway is a low-risk, chronic mechanical interface between the device, the respiratory muscles, and the cardiac cycle. This clinical timeline outlines the parameters of the first-in-human VisONE pilot study, tracking patient outcomes over a 12-month observational period. The cohort consisted of 15 symptomatic men with ischemic heart disease, all of whom were already fully optimized on guideline-directed medical therapy. Crucially, they had to meet a strict electrophysiological requirement, a QRS duration of less than 120 milliseconds. This guaranteed the cohort had no baseline ventricular dyssynchrony. Immediately following lead placement, the surgical team conducted an acute intraoperative testing phase while the patients were still monitored. The immediate hemodynamic data proved the concept instantly. Temporary activation of the ASDS system yielded a 17% increase in cardiac output. Furthermore, this significant increase in output occurred without any corresponding elevation in the patient's heart rates. The early chronic effects mirrored this efficiency. During the first month of continuous outpatient therapy, resting heart rates actually decreased. These acute and subacute metrics validate the core physiological hypothesis. ASDS mechanically offloads the ventricle, allowing the heart to generate higher stroke volumes with lower energy expenditure. These charts capture the 12-month chronic efficacy data, examining how continuous ASDS therapy impacts ventricular structure over the long term. The key variable in these outcomes is the SDS dose response. The therapy's efficacy relies entirely on the device successfully sensing the R wave to trigger synchronized pacing. In this first-generation device, there was a technical hurdle. Diaphragmatic EMG noise generated during normal respiration can obscure low-amplitude R waves, occasionally reducing the percentage of accurately synchronized beats. However, by isolating patients who achieved at least 80% accurate synchronization, the remodeling data became profoundly clearer. Left ventricular end systolic volume plummeted from 136 down to 98 milliliters, and correspondingly, ejection fraction increased from 28 to 34%. This clear, dose-dependent reverse remodeling proves that mechanical assistance from the diaphragm can directly alter the trajectory of heart failure. Driven by these sustained structural improvements, the FDA granted the ASDS system Breakthrough Device designation in 2020. By addressing preload reserve and pericardial restraint mechanically rather than pharmacologically, finding a new way to assess these patients requires looking past the heart to its immediate anatomical neighbor, the diaphragm. Standard anatomy defines the diaphragm as the primary muscle of respiration, dedicated to the expansion of the lungs. Mechanically, this muscle also functions as a pump for the cardiovascular system. Precise pacing of the diaphragm can modulate cardiac hemodynamics, aiding the heart's performance without increasing its oxygen demand. By mapping pressure changes, we observe the respiratory pump mechanics. When the diaphragm contracts, intrathoracic pressure drops and intra-abdominal pressure rises. This vacuum effect pulls blood upward from the abdomen and extremities, recruiting central volume, increasing preload reserve, and boosting right-sided stroke volume. Beyond pulling blood toward the heart, the diaphragm's movement physically alters the space the heart occupies. A failing ventricle often struggles to fill because it is restricted by the pericardial sac, a limitation known as pericardial restraint. Because the pericardium is tethered to the diaphragm, the downward pull of a contraction stretches the sac. This lowers localized pressure and physically opens space for the left ventricle to expand. Natural diaphragmatic movement unloads the heart by simultaneously increasing preload and lowering pericardial restraint. This mechanical linkage provides a direct physiological pathway to modulate cardiac performance without stimulating the myocardium. The VisONE system synchronizes pressure drops with the heartbeat. It uses an implantable pulse generator, 2 bipolar active fixation leads anchored into the diaphragm, and a delivery tool. Implantation uses a minimally invasive abdominal laparoscopic approach, avoiding the trauma of opening the chest. Surgeons attach a sensing lead to the right inferior surface of the diaphragm and a stimulating lead to the left. The leads are tunneled to a subcutaneous pocket housing the pulse generator. This chest X-ray shows the final internal architecture. The system remains entirely below the heart, operating from within the abdominal cavity. In the first inpatient trial, surgeons achieved a 100% implant success rate with an average procedure time of 73 minutes, demonstrating the practical feasibility of the approach. For the diaphragm to act as a cardiac assist, its contraction must be perfectly timed to the active cardiac cycle. The sensing lead continuously monitors the heart's electrical activity, detecting the intrinsic QRS complex. Upon detection, it initiates a precise programmed delay, waiting for the optimal moment before delivering a synchronized pacing spike to the diaphragm. However, continuous electrical pacing of a respiratory muscle raises concerns about chronic hiccups or muscle fatigue. During surgery, the device is calibrated to find the capture threshold, the minimum voltage required to trigger a contraction. Surgeons then identify the symptomatic threshold, the point where a conscious patient feels the stimulus. The device operates safely between these thresholds. This ensures the system provides a massive mechanical assist while remaining completely imperceptible to the patient. To evaluate the long-term impact, researchers followed 15 symptomatic men for 12 months after implantation. This chart shows the structural cardiac remodeling. Over 1 year, left ventricular end systolic volume decreased from 136 to 98 milliliters, significantly improving 6-minute walk distances. Matching these physical changes, this radar chart maps improved quality of life scores, showing massive reductions in physical and emotional role limitations. The data suggests a direct link. Physically unloading the heart drives structural remodeling of the ventricle, which in turn restores physical capacity. A final interrogation of the devices revealed that the degree of recovery was tied to the consistency of the pacing. Researchers compared patients who received inconsistent pacing with those who achieved successfully synchronized beats over 80% of the time. These charts show that the 80% synchronization group saw even steeper improvements in cardiac remodeling and physical performance. This dose-dependent response indicates a direct mechanistic link. The more frequently the diaphragm assists the heart, the more the heart recovers. These findings suggest that for patients who have exhausted traditional therapies, the mechanics of a non-cardiac muscle can be used to drive clinical recovery. Ultimately, the life-changing result is a patient capable of walking freely without the severe physical restraints of refractory heart failure. Synchronized diaphragmatic stimulation is a feasible and safe new vector for treatment,